Good morning, everyone, and welcome to this session on sick day rules. I'm just going to leave it a couple of minutes to make sure we let everyone in. So if you sit comfortably, and we'll begin in just a moment or two. Okay, I think now's a good time to begin. So very good morning, very warm welcome to everyone today. I hope you enjoyed the sponsor session earlier today, if you were able to sit on that. And if not, I strongly suggest you visit the sponsor booths if you can, just to see what the latest developments are that they're offering at the moment. They're always very helpful. So this session now is a very good one. I'm Emma, by the way. My son Hugo is type 1 diabetic. The session we have now, we have Brian Kennon, Dr. Brian Kennon and Jude Kennon, who are consultant diabetologist and diabetes specialist nurse, respectively, and they have many years of experience between them and have been very heavily involved with the Friends for Life conferences over a number of years. Brian is the medical advisor to type 1 today. And between the two of them, you can imagine they have an absolute wealth of knowledge that they're going to impart some of it to us today. Now, sick day rules is something that none of us want to hear about at all, but obviously all of us need to know about for the time that that when we do need to know it. So hopefully we'll see what the latest suggestions are now. And so I'm going to hand across to Brian and Jude. But during the session, please do use the chat function, press the button at the bottom and write down if you have any thoughts, any questions. There's also a question and answer. But if you put those in there, during the session, I'll monitor those and I'll make sure that hopefully if we have time, we ask all the questions at the end. So everyone can get what they need from this session. So sit back and enjoy. I'll pass across to Brian and Jude.
Yeah, hi there. Good morning, everybody. And apologies if you were at the session last year, because it's pretty much the same session. It was just we were asked to run it again for any new attendees. So when the numbers drop off and everybody dials out, will not be offended. And actually, despite Jude and I appearing as two different people in different places, we're actually beside each other, but we're using two different laptops. So as Emma said, thanks for the introduction. Keen to use the chat function to answer questions and answers, but we're going to run through a bit of a presentation, but also try and get your opinions on some stuff as well. So we're asked to cover sick day rules and really keeping you as safe as possible. And this was particularly topical last year because obviously we were in the middle of COVID pandemic, but arguably we're still in the middle of a COVID pandemic. So I think probably still quite relevant. So we're going to go over diabetes and ketones, diabetic ketoacidosis. Jude will focus on specific sick day rules and then just a couple other tips. But we're happy to hear from other people who've got other thoughts and ideas and any questions you might have, as we say. So the first one is a poll. So we really just want to know from the outset how confident you feel about managing diabetes during your illness and following sick day rules. So we'll launch that poll just now. Are we launching that poll? We are just about to launch that poll. And it goes from 1, very, very confident, down to 6, never heard of sick day rule. So if you want to just answer that quickly, then that would be great. Waiting to see the response. Give you 3 more seconds. Jenny, how many replies do we have?
19.
19 will do us. Well, let's go with that. And can we just share that? Okay, so no very confidence, but a few confidence and 1 never heard of sick day rules. Good. So for 1 person at 19, hopefully this will be a useful talk for you and we'll see how we get on. Okay, so moving on, then I'm just trying to see if I can move on. We're going to go for audience interaction, and who better than to help gender that than Ainsley Harriet. And instead of Ready, Steady, Cook, we're going to play Ready, Steady, Ketones. So here's your first question. So is it red tomatoes? This is only people with diabetes get ketones. Red tomatoes, true. Green peppers, false. And we'll launch poll number 2. Again, we'll just give you a few seconds to answer that to get your thoughts. So only people with diabetes get ketones. Red tomatoes, true, or green peppers, false. Splendid. Let's close the poll and share the results. So 19 out of the 20 false, and false is indeed the correct answer. So well done to everybody there. And I think it's getting caught up with the timing of the poll, so bear with me 1 second till I move us on. So if you look at insulin and how it is responsible for glucose metabolism, apologies for people who know this already, but if you have a working pancreas, then your insulin gets released. And the main role of insulin is to try and help glucose move into the cell. And it binds to the insulin receptor, opens up your glucose channels, and your glucose moves into the cell and you can use it as fuel. I'm sure as many of you are aware, in type 1 diabetes, then the cells in the pancreas that produce insulin, so your beta cells, get destroyed. So you actually don't have any insulin at all, and therefore you can't utilize that glucose. And that's why you need to replace it via injections or a continuous infusion. In type 2 diabetes, it's slightly different. Quite often, individuals often produce too much insulin because they're very insulin resistant. So it's just that the insulin that individuals produce, the cells are more resistant to them, and therefore they struggle to take up glucose. So what happens when you can't use glucose as a fuel? So in type 1 diabetes, if you are insulin deficient, then your body's very selfish. It needs fuel from somewhere. And if it can't get it from glucose, then it starts to break down fat. So when it breaks down the fat, these fatty acids are used in the liver to create ketones, which you can then use as a fuel. But what happens with ketones is that they can also produce a buildup of acid as well. So what the problem with ketones is that they can develop really quickly if somebody's insulin deficient, because you're breaking down fat, and the byproduct is also to develop a buildup of acid. Now, you may well have heard, and in fact, there's a talk tomorrow from Fiona Kennon, who's actually our sister-in-law. She's a family therapist with expert on eating disorders. So diabulimia, when you use insulin emission to control your weight, that's actually the basis of how you use insulin emission to control your weight. It burns up fat. And in fact, for anybody who's tried the Atkins diet, then the low-carb diet, then you're effectively making your body insulin deficient, so you burn fat. So diabetic ketoacidosis, well, why does it develop? So this is your next question. Does it develop as a result of red tomatoes insulin deficiency or green peppers high blood glucose? And we'll launch that poll. Again, we'll just give you a few seconds to answer that. Okay. 22. Good. So yeah, we'll close the poll there, I think. And we'll share the results. Yeah, so it's funny. So when I give this talk to junior doctors, most of them say high blood glucose. But the actual fundamental problem in diabetic ketoacidosis is insulin deficiency. So although you get high blood glucose as a consequence of the insulin deficiency, it's not the cause. The cause of DKA is insulin deficiency. And that's why, as we'll talk about in a minute, sick day rules all revolves around extra insulin to treat that insulin deficiency. And this is a bit more of the science part of it. So as I've said, in insulin deficiency, you break down fat. It increases acid. Now, your body, despite having a blood glucose of 20, doesn't know that because it can't use it as a fuel because it can't move into the cell. So you actually produce glucagon. And I'm sure many of you will be aware of glucagon. It's the orange syringe that you get to treat hypoglycemia. Well, your body, despite having a blood sugar of 20, might still think it's relatively glucose deficient. So it actually produces glucagon, which causes even more glucose release, and you get increased ketone production. And the net result with high blood glucose is it causes you to lose water and salt, and high ketones also cause you to lose water and salt. So very quickly in diabetic ketoacidosis, you can end up dehydrated, salt deficient, and have very high acid levels in the body. So that's why you get DKA. You get DKA because of insulin deficiency. But what's the commonest cause? So do you think it's red tomatoes, intercurrent illness, or green peppers, insulin emission? Launch that poll. And I'm looking to our technical advisor to see how many replies we're having in. 22. Splendid. I think we'll close the poll there. We'll share it. So the cynics slightly win that vote at 55% versus 45%. If I give this talk to healthcare professionals, about 90% think the commonest cause of DKA is insulin omission, because obviously as healthcare professionals we like to blame the individual with diabetes rather than actually other causes. But actually, commonest cause is intercurrent illness. So this next graph shows you about who gets DKA and why. So we know that every year about 1 in 9 people with type 1 diabetes will develop ketoacidosis, and that 25% of people developing type 1 diabetes will be in DKA at diagnosis. That's actually higher for the under 5s. It might be as high as 40 or 50%. And the commonest reason is intercurrent illness. It's infection, which is why sick day rule guidance is always really around infection. It's not to say that non-compliance isn't quite high. That can be a common cause in about 1 in 4 episodes of DKA, or indeed concerningly inappropriate advice from healthcare professionals can also be a cause. But the commonest cause is definitely intercurrent illness and infection. So what are the symptoms of DKA? Well, the first thing you get is the high blood sugar symptoms. So increased urination, drinking, you get dehydrated, so very thirsty. But very quickly you can develop nausea and vomiting and indeed abdominal pain. And quite often when you see somebody coming in with DKA, the doctor who assessed them says, oh, it must be due to GI upset because you've had vomiting and abdominal pain. That's often not the case. The vomiting and the abdominal pain is the consequence of the ketones, not necessarily the cause. And because you get high acid levels, you're trying to correct that, and your body tries to correct that by breathing very, very quickly. And if things go unchecked, then you can end up with reduced conscious level, and obviously that becomes potentially life-threatening. So this is a typical clinical scenario. So just running through a sort of real-life case, and this is based on experience to date. So John's 19 years old. He's had type 1 diabetes for 9 years, and his HbA1c isn't where he would want it, he's 78. He is on a basal bolus regime of Novorapid and Levemir, but he's had 3 days of diarrhea, nausea, and feeling generally unwell. He's not eaten much because he's just been feeling rubbish. Sugars have been sitting a bit high. And because he's not eating very much, NHS 24 were worried about him getting too much insulin, so they advised him to decrease the insulin. I'm glad to see that Emma is shaking her head going, oh no, oh no, no. So in the chat function, just quickly answer yes or no. Do you think that's good advice? I'll give you 10 seconds to just put something in there. The diabetes community is spoken. We've got a resounding no. And I like the person who's going, no! Yeah, so good. The reason I'm highlighting this is because often when you phone NHS 24 or other healthcare providers, you hope the advice you get is going to be sound. I must admit that in type 1 diabetes, particularly around sick day rules, the guidance sometimes isn't, and sometimes you do get advice to cut back your insulin. The bottom line is if you're unwell, your sugars are high, you need more insulin. So I'm glad that everybody's said no to that. My laptop's playing up again. So the reason why you need more insulin is because during illness, your body produces lots of stress hormones. And the commonest stress hormones you have would be steroids, so cortisol and adrenaline. And both of these hormones, the real job is to try and get you more fuel so that you can fight infection, so that you can actually help recover. But actually in somebody with type 1 diabetes, it makes them more insulin resistant, it puts their blood sugars up, and you then get a greater risk of developing ketones. And of course, as I've already said, these high sugars cause you to become dehydrated because you pass more water. So next poll is, you only need to check ketones if your blood glucose is high. Do you think that's red tomatoes true or green peppers false?
Try not to shake my head or nod my head here, so to give anything away.
You're not allowed to lead the
I'm
witness.
sitting deathly still.
Yeah.
21 responses.
21 responses, good. Thank you for staying with us and humouring us. We'll share that now. Yeah, so false is actually the right answer. It's not, and I'll explain why in a wee second. So we would advise, and I think to be honest, most healthcare teams would advise that If you feel unwell at all, you should always check for ketones, irrespective of your blood sugar. So don't just check ketones if your sugar's high. The 2 times that we would advise checking ketones would be 1, if you have a persistently high sugar that you don't know why, or 2, if you feel unwell, irrespective of your sugars. And we do see something called euglycemic ketoacidosis, which means you have a normal blood sugar, but you can still develop progressive buildup of acid. So you've almost got enough insulin to control your sugar, but you don't have enough insulin to switch off ketosis. So definitely, if there's one take-home message, if you feel unwell, check your ketones, please, irrespective of your sugar. And moving on now to, so hopefully we've covered sort of what DKA is, what ketones are, why you might get it. Now we're going to focus on sick day rules, and this is really the guidance for people with diabetes and how to keep yourself safe. So sick day rules are a bit like the emergency exits in planes. You hope you don't need them, but you sure as hell want to know where they are when you do. And I think that's one of the common things we hear is, oh, I did have sick day rules, but I couldn't find them when I was unwell, or I was too unwell to go downstairs to hunt in the drawers to find them. So what I would say as a plea is to try and make sure that you've got these sick day rules handy. And increasingly, we advise people to put it on their mobile device. So take a picture of your sick day rules and keep them on your phone. The other thing I tend to say to people, and I know Jude says the same, is that most people now have mobile phones, and in your mobile phone, you've got a health app where you can put medical ID. I'm sure most of you have already done this, but if not, then I would encourage you all to put that in there. And the reason is that when paramedics used to find people with medical conditions, they would hunt through wallets or pockets for medical ID. They'll still do that, but the first thing they'll come across is a mobile phone. And even if they can't unlock it, they can access your emergency information. So having in there that type 1 diabetes, potentially what your treatment regime is, can be quite useful. And it's the same chat we give for the teenagers around alcohol and the risk of hypos. So make sure your medical ID on your phone has that. And I think most people find sick day rules quite confusing. And I'm going to share with you some insights we have from the medical community, which probably highlights why sick day rules to people with diabetes and their parents and families are so confusing. And this is a bit of work we did in Scotland a few years ago. We wanted to try and standardise sick day guidance. We thought, this is ridiculous that every unit tells you different things. Why don't we standardise it? So in an attempt to do that, we asked healthcare professionals what their guidance was to patients. So we said, at what level of blood glucose should you check for ketones? And I'm just going to share you with the answers. Well, you can see here that the advice varied from unwell, 10, 11, 14, 17, and the advice even varied within the team. So if we aren't providing consistent messages within a team, how on earth are individuals with diabetes and their families supposed to know what to do? So I think the general advice now would be unwell or blood sugars repeatedly above 14. We then said, well, what would you do if you had some ketones, but they were less than 0.6? And everybody agreed. This is the only answer where all healthcare professionals agreed. You do nothing, just take your usual correction dose to bring your sugars into target. When your ketones get a bit higher than this, then we asked, well, what would you do if your ketones were 0.6 to 1? And if you look here, this advice varies from do nothing. One of the replies was follow healthcare advice, which was obviously what we were trying to find out from the survey anyway. And the other advice is take somewhere between 10 and 20% of your total daily dose. So quite disparate guidance across healthcare teams. What would happen if your ketones went up a bit higher from 1 to 1.5? Well, this really went from taking additional insulin, again, somewhere between 10% to 20%, but there was definitely an indication here you should be thinking about taking extra insulin. And as I've said, ketones is a sign that your diabetes is starting to decompensate, which is why extra insulin is required. And when it got above 1.5, then the advice went from you're at risk to DKA, seek urgent help, to go to A&E, to take double your correction dose, to take 20% of your total day. So you can see very quickly, I'm not using this as an example of what you should do, but more why this is so confusing, because the guidance varies so much. And the one thing we should have said right at the beginning is we feel that the most important thing is you discuss this with your own healthcare team. And we're not here to tell you how to manage sick day rules. We're here to just give basic principles, but the advice you use should always be from your own team. So Jude's now going to talk through what we give advice as a Daphne Centre. You want me to unmute?
Yeah, if you mute yourself and unmute me, I'll save any. Oh no.
Okay.
Not you? Can you put your volume down as well, please? Is that you? Sorry, we're just trying to stop feedback happening in our own room here. Perfect, thank you. I just didn't know if you wanted to answer the questions first before we went on to the sick day rules.
Oh, we've got questions coming in? Okay. So if we've got questions coming in, we can maybe do those before we went on to sick day rules. Yeah.
Well, we've actually got a couple. Shall I go ahead and ask? And we've got Christopher has asked, if DKA is caused by insulin deficiency, is that why you can get ketones from exercising sometimes?
Do you want me to take that? Yeah. Sorry, because we're working off two laptops, we're getting the possibility of echo here, so apologies. Yeah, so I think one of the issues with exercise is that quite often people cut their insulin quite back significantly, and that does run the risk of making you quite insulin deficient. So depending on when you exercise, when your last insulin injection was, you can run the risk of becoming insulin deficient. It's, you know, when I first started as a registrar, and I bear in mind that's 20 years ago, it used to be, oh, start your sugars at 12, and when you exercise, it will drop to 6 and you'll be fine. We realise that that guidance is terrible, and Alistair Lum is doing a really nice talk on exercise that I would encourage you to try and dial into. You always want to have some insulin in your body to move the glucose into your cells so that you can use it as a fuel. So if you get the balance right, and I'm not saying it's an easy balance depending on the exercise you're doing, then you shouldn't really develop ketones during exercise.
Fantastic. The next one we have, Martin has asked.
Sorry, Emma, I was struggling to hear you there, sorry.
Oh, can you hear me now?
Yeah.
Okay, perfect. Martin has asked, if you have, you were talking about if you have normal blood sugar, but you have ketones, and you called it something, I didn't catch the name of it. But he said, is that the same as starvation ketones?
So slightly different. It's called euglycemic, and euglycemic means normal blood sugar level, euglycemic, normal glucose. So starvation ketones would be you just haven't got any carbs in your system, so your body isn't producing any insulin. Euglycemic ketoacidosis is different. You may have some insulin in your system, but it's not enough to combat the ketosis process. So it might be enough to keep your sugars reasonable, particularly if you've not been eating very much, but it's not enough to switch off that drive to break down fats, to produce extra fuel, to build up acid. So the bottom line is it's often the same outcome, and it's why monitoring ketones becomes so important. I get less vexed with starvation ketones. If people with type 1 diabetes go on low carb diets and they've got a bit of ketones in the morning, but when they eat something and take their insulin, they disappear, that's fine. Whereas euglycemic ketoacidosis is really a sign that your diabetes is decompensating significantly because there's something else going on.
Fantastic. Thank you very much. I have another question, if you like, unless Judy's ready for the next part. I'll fire away quickly. I find personally that when my son, when he's coming down with an illness, his blood sugars go high, and then when he has the illness, they go low. Recently, he was a bit poorly and he went low, and he was very low during the illness. Is there a typical, or is it can go either way?
All right, sorry, I wasn't sure if Jude was taking that question or not. Yeah, so what I would say is infections tend to deal differently in different people. The general rule of thumb is that it'll put your blood sugars up in the early phases of it. And in fact, one of the things I tend to say to our trainees, particularly in my foot clinic, is if you see somebody and you're worried about their ulcer being infected, ask them about their sugars, because one of the first signs long before explain 24 hours of high sugars. So just as you've articulated them there, Emma, your son will get high sugars even before he probably develops the illness. And then when he gets the illness, well, it partly depends what your illness is, because quite often if it's a, vomiting or something that's making you nauseated, you might not be taking in that much oral intake. So your insulin sensitivity you can be quite sensitive to the insulin that you're taking. And obviously, if you're taking additional insulin, it might put you at risk of your sugars running a wee bit lower. I think the key thing, and Jude will touch on this, is just regular monitoring and adjusting your insulin. So clearly, we don't want folk being hypoglycemic when they're unwell, but conversely, the biggest risk is of ketoacidosis. The other thing to say, there are certain types of infection that can put you at risk of hypoglycemia. So what we call gram-negative bugs, they often cause things like urine infections and gallbladder infections. They historically, even in people without diabetes, would put you at risk of hypoglycemia because of the way that it's got a glucose hunger, the way that illness affects your body. So the type of infection, but it is very individual. And the most important thing is that it's a dynamic situation. So it's all about frequency of monitoring and reacting to those results.
Fantastic, thank you.
Sorry, I had to unmute there. So I'll go over some examples of sick day rules. As Brian said, Brian and I both work within Glasgow, and all the hospitals within Greater Glasgow and Clyde are Daphne centres. So the sick day rules we use are following Daphne guidelines. Daphne is a structured education course that is used throughout the UK. We would say that if you've been given separate sick day rules from this, follow the ones that your centre have given. Most of them are a variation on a theme. So these are the ones we use. The first law are for those individuals on injections, and then I'll go over the separate pump guidance. So first step is, as Brian had already said, regardless of what your blood glucose is, if you're feeling unwell, check a blood glucose and check a ketones. And they separate whether you've got ketones or not. That's how it's defined as a severe illness or a minor illness. And we go on a flow chart. So no ketones is a minor illness. So the rules we would suggest you follow is you're feeling unwell, no ketones, sip sugar-free fluids, at least 100 mils an hour it suggests, and check your blood glucose and ketones every 4 to 6 hours. Or if you have ketones that are above 1.5 on a ketone meter, it does say urine here, but we would just recommend everybody has a blood ketone meter, and I know that was asked on the questions as well. So we would just say check blood ketones. The urine's lag behind and it's not as accurate. You don't get a number, you get pluses. So definitely on a blood ketone meter. And if you've got ketones of above 1.5, it would be checking your blood glucose and ketones every 2 hours. I need to do the slide, sorry. So the minor illness, so this is if you've got no ketones present, our guidance would be take your usual dose of quick acting insulin to carb ratio when you're eating. If your blood glucose is above target, then you just use your normal correction doses. If your blood glucose is within target, then if you're unable to eat, you would just take your background insulin, although that may need adjusted as well. So often people find that they can get away with a minor illness with no ketones just by adjusting or increasing their background illness by 1 to 2 units. If you're vomiting at any point, unable to eat, unable to control your blood glucose levels, get yourself to A&E. It's always an emergency, and never stop taking your background insulin. So a severe illness, this is how we'd class any illness with ketones that are above 1.5 millimoles. This is when I think when people are feeling unwell, this is the guidance that gets a bit lost and it's a bit confusing. I think, as Brian's already touched on, we as healthcare professionals have a bad habit of making sick day guidance more complicated than it needs to be. And this example is probably not changing that view that I have. but I'll go over what I suggest after I've gone over the guidance. So essentially, calculate your typical total daily dose. Your total daily dose is all the background insulin and all the quick-acting insulin that you would take on an average day. Okay. If your blood ketones are between 1.5 and 3, then we would suggest taking 10% of this total daily dose every 2 hours in the form of your quick-acting insulin. If your blood ketones are above 3, we'd recommend taking 20% of your total daily dose every 2 hours. So an example of this would be if you're on Levemir, 10 units in the morning, 12 in the evening, you would calculate that up to take, it would be 24 units. If you then, on a typical day, would take 10 units of Nova Rapid with breakfast, 6 with lunch, and 10 with your evening meal, you would add all that up, which makes 26. You would then add your 24 and 26 together, making 50. So the total daily dose would essentially then be 50 units of insulin. I've done that math myself so that it makes it easier. So 10% of that would be 5 units, 20% is 10, and you would take those units in your quick acting. So for my example, Nova Rapid. So if your ketones are between 1.5 and 3, we would expect you to take 5 units of Nova Rapid every 2 hours until those ketones are gone. If your ketones are above 3, we would suggest taking 10 units of your Nova Rapid every 2 hours. However, the guidance we suggest is if they are above 3 on your second check and they're not coming down, get yourself to A&E. We'd class that as an emergency. So we've got some case studies here, and I'll just go over them just to reiterate the guidance. So John, 19 years old, has diarrhea, Levemir, 12 units twice a day, and his Nova Rapid averages at 26 units a day. So his total daily dose again is 50. I think you can tell it's me that's made these up because I'm keeping the maths easy. His blood glucose is 18. So when he checked his ketones, we would suggest if they were above 1.5, take your usual correction dose. Sorry, less than 1.5, you would take your usual correction dose of Nova Rapid. If they're between 1.5 and 3, it'd be 5 units of Nova Rapid every 2 hours. If they were above 3, it would be 10 units of Nova Rapid. And again, if you check again in the 2 hours and they're not coming down, we would seek urgent help. And again, always is the case, if you're in any doubt, seek help. NHS 24, phone your centre if they're open, or get yourself to A&E. The next examples is what we'd advise if you were on an insulin pump. So this is if you've got a blood glucose of above 13.9. Now the guidance we give is if your blood glucose is above 13.9, assume there's something going on with your pump, whether you're ill or not. The first suggestion is we would take a correction dose of insulin via your pump and recheck your blood glucose in 1 to 2 hours. If your blood glucose is still above 13.9, or if you feel unwell, check your ketones. Ketones of less than 0.6 is negative in a trace, and we would suggest at this stage taking a correction dose of insulin via your pen, change your infusion sites, your set, your reservoir, and your insulin, and consider taking an increase in your basal rate at 20%. Recheck your blood glucose and ketones in 1 to 2 hours and repeat the advice until your blood glucose is back to within your target range. If your ketones are 0.6 to 1.5, which is where the guidance changes a bit from if you're on injections, we would then class this as positive on a pump. It would be taking 10% of your total daily dose or your usual correction dose, whichever one you get more insulin from, of quick-acting insulin via your pen again. Increase your basal rate by 30% via your pump, and again, change your infusion site, reservoir, and insulin, and again, you're rechecking your glucose and your ketones every 1 to 2 hours. If your ketones are 1.6 to 3 millimoles, we'd advise taking 10% of your total daily dose or correction dose, again, whichever is greater, via your pen, and increasing your basal rate on your pump by 50%. And again, it's changing everything, your infusion site, infusion set, reservoir, and insulin, checking your blood glucose and ketones in at 1 to 2 hours. And ketones of above 3 millimoles, it's taking 20% of your total daily dose of insulin via your pen again, increasing your basal rate by 75%, and changing all your site set reservoir again and rechecking 1 to 2 hours. And in general, to try and simplify things, because as I said, there are sick day guidance we give out. Most people will phone us and say, I'm rarely sick. When I do feel sick, I don't feel like looking up the sick day guidance. I can't work out the maths. I would always advise writing down your total daily dose on a day you feel well, on a day that you've not taken more corrections or less insulin, just an average day. Total up the amount of insulin you normally take, and that's your total daily dose. Keep that written down somewhere on your phone, and the 10% and 20% of that, so you don't need to go hunting through bits of paper. But in general, the advice is keep hydrated, try and eat and drink what you can. If you're unable to eat solids, then we'd suggest sipping on sugary fluids, Lucozade. Treat any nausea, and that's an important point that actually neither of us touched on. We are discussing here sick day guidance in terms of diabetes, so what to do when you've got ketones. Treating your ketones will not treat any underlying infection, or if you've got a temperature or a cold. So we would suggest taking your normal over-the-counter paracetamol. If you think you've got an infection, obviously speaking to your GP, getting antibiotics if you need them. If you've got nausea, getting on an antiemetic. Our guidance in diabetes is just for the ketones, so any underlying illness that you may have will also need to be treated. Sorry, so that was my point on treating nausea. Resting, avoiding exertion, frequent blood sugar monitoring, checking your ketones, keeping with an insulin schedule. So as we suggested, checking ketones and blood glucose every 2 hours. Give extra insulin when needed, and if in doubt, get yourself to A&E, call a doctor, call your centre for advice. There you go, I've muted.
Oh. Sorry, trying to find unmute. The thing that people would like to do to me frequently is mute me, and I can't unmute myself. Yeah, so this is just a summary slide, really. What we didn't touch on was about ketones often go out, strips often go out of date. So just make sure your ketone strips are in date. That's really important. I would agree with Jude. I think the days of urinary ketone testing should be gone.
Yeah.
I think you should be saying, if you've been told to urinary ketone test, you should be pushing to get blood ketone testing. I just think that we need to try and drive that agenda. The accuracy of your blood ketones are much better than your urine ketones, and your blood ketones are often more dynamic, so they're more up to date. Your urinary ketones can lag behind a wee bit. We've already said, and we banged on about checking your ketones if you're unwell, irrespective of your glucose. And I think Jude's point's valid as well. Lots of people control their ketones really well during intercurrent illness, but some of the sickest DKs I've seen are the people who've come in with like pneumonia or gallbladder infection, because they manage their ketones brilliantly, but clearly managing your ketones won't treat a pneumonia or a gallbladder infection. So you need to be mindful that your illness that's causing this may well need treatment as well. But most instances when people come in with ketones, DKA, quite often it's because they've not checked ketones at all. So it is about having the ability to do that. And put sick day rules somewhere you'll remember them. And as I say, we're a big fan of the phone, because everybody's got their phone attached to them all the time. So happy to open that up to questions and discussion. But we'll maybe get you to finish the last poll before we do so, which was just reassessing, just on the basis of that 40-minute update, how confident you feel. And to be honest, you see, if you don't feel any more confident and there's still a query you've got, then we've got 5 minutes to take some more questions. Okay, are we closed it? Yeah, that'll do us. We've got some people that have stayed to them. Will we share that? Is that okay? Okay, so good. We've moved from the never heard of sick day rule. So there's a change there. So the change was in the right direction, which is reassuring. It's always a worry when you put a poll in at the end. Everybody goes, you've just confused us even more, and now we're very uncertain. So thanks for humouring us.
It's moved
Happy
up.
to open up to further questions.
Well, thank you. I found that very useful. I'm sure everyone did. We have a question from Ed.
Oh, I can't hear. Sorry, didn't hear you there, Emma. Sorry.
Okay, I'll say thank you so much, Brian and Jude. That's been really, really helpful. We've got a question from Ed. Any guidance on adapting the rules if on Control IQ or similar on pump?
Just work with one. Yeah, that's a really good question. It's really difficult. So the first thing I would say is, if you're developing ketones on your pump or Control IQ, you should assume your pump's not working. I know that's a ridiculous thing to say, but we always, the whole idea of the safety and why the guidance for pump users is always go to your pen early is because you don't necessarily know your pump's working. So I would definitely reiterate the advice about completing all your set change, different insulins, reservoir change. And if in doubt, run a self-test on your pump as well. When we're talking in the sponsor session, we're talking about how the closed loop systems are often very good at managing your sugars, and you run into more problems than you solve when you try and second guess them. That's probably difficult for the algorithms. Now, some of the manufacturers might correct me if I'm wrong, but Control IQ, auto mode with Medtronic pumps, none of them do particularly well with extremes of sugars. So during intercurrent illness, they really struggle. The algorithms just struggle with that. So CAMS APS probably adds a different dimension. I think in doubt, you need to be taking correction dosages, and the Control IQ can only cope with so much, and quite often they'll kick you out of auto mode and into manual mode, so that they do encourage you to sort of take corrections, keep an eye on your ketones, take corrections, keep an eye on your ketones. But generally, as a rule of thumb, when you're on a technology, then you want to make sure it's working properly, and if in doubt, take your insulin via your pen.
Fantastic. Thank you very much. I think your note about the ketones, the test strips can go out of date is very valid. And I don't know about everyone else, but when I do get ketones on prescription, the ketone test strips, you don't actually get that many. Yeah. And so, and this is a big reminder to me actually, because Hugo was a bit poorly last week. And so I was testing his ketones and I'm just thinking, I need to check I've got enough. I need to do another prescription request. So when you do, if you're testing the ketones every 2 hours, I think that's what you guys suggested, then you can go through quite a few test strips in 24 hours. So that's a good thing to note. Rebecca has noted that she's only 2 months in. My goodness, it's still very early days for you. Do not expect to listen and remember each one of these words. I think the important notes that both Brian and Jude have said is keep a print of your sick day rules, keep it handy. I certainly have got one in a folder, and if ever I need it, I just go, first thing I do, I go and get my sick day rules out and check through that. So you don't need to remember everything, but you just need to know where to go and find it so it can jog your memory what you need to do.
And I'll just answer Rebecca's question about the Libra 2 very quickly, because I see that Glenn said we've got 2 minutes. So the Libra 2, no, you can't check for ketones on that. We'd normally give someone a separate keto meter to keep for specifically that reason. So if you haven't got one, I'd ask my centre for a meter that can test for blood ketones.
Yeah, if you've got type 1 diabetes, you should be able to check for ketones, and you might get a less expensive ketone monitor to use. So, you know, because obviously the reader for Libre can take ketone strips as well as glucose strips. So they might give you an alternative. But yeah, gone are the days, I think, when type 1 diabetes should not have ketone or urine ketones. We should be driving for blood ketone monitors. And I think we're all of one mind on that.
Fantastic. I think you've answered everyone's questions, and I think it's been really helpful actually having the questions coming through. I found it very helpful as well. So I'd like to, unless anyone's got any other questions, I'd just like to thank Brian and Jude, very helpful for us. It's nice to have, this is another backup for as and when we do need to deal with sick day rules. This will hopefully give us the confidence. And it was very reassuring, wasn't it, to see on the poll that you put out, the lines were down lower. They definitely moved up. So I think it's been very helpful to everyone. So thank you ever so much, both of you. Thank you.
Yeah, thanks everybody for dialing in. Cheers.
Have a good day.